Look, I'm sorry, I can't find the bio right now. Welcome to the stage, Ivan Frkovic from the Queensland Mental Health Commission. He's coming to talk to us about improving the physical health of people living with mental illness, but looking at opportunities for reform. Welcome, Ivan. Apologies.
No problem. Thank you very much and good morning, everybody. Can I start just by acknowledging the traditional owners and paying my respect to elders past and present, and just thank the Equally Well Australia team for the work they've done to actually bring together this particular symposium, but also to put a focus again on physical and mental health. It's probably hard to follow people like Sam and others this morning about what can you say, because I think some of the evidence and data that Sam actually presented clearly indicates that the evidence is there, but how do we implement this from a more systemic perspective? And I suppose from where we sit as the Commission, we're trying to work really hard at really, embedding this within both the general health system, but also the mental health system. I'm probably not saying too much when I say that mental illness in combination with other chronic diseases represents one of the biggest challenges to the public health system in Australia. And as we are all aware, there is a two-way relationship between mental health and physical illness, particularly issues such as cancer, heart disease and diabetes, as we've heard regularly this morning. But despite this, the strong links between mental and physical health are not yet broadly reflected in public health policy and, can I say, in service delivery. We've got some pockets of examples, and I think Sam and others are great pockets of examples, but how do we achieve that more systemically? About 12% of the Australian population is estimated to have both a mental health condition, but also a chronic physical health condition. People who live with a combination of physical and mental health fare worse than people with one or the other. And as has been said, people with mental health conditions die 15 to 20 years earlier. And I think that should be something that we should keep as our Northern Star about what should we be working towards to achieving and reducing that. And can I say, from where I sit from a sort of a systems perspective, this is not an acceptable outcome in a modern healthcare system that we have here in Australia. Can I say that I regularly hear, and I do travel the state pretty regularly and talk to people with lived experience, families and carers, but also clinicians, of instances where persons' physical health needs are overlooked while mental health issues are treated separately or in isolation. And can I tell you, only a couple of weeks ago, an example of where a person turns up to ED who has a long-standing chronic mental illness. He turned up to ED not to do with his mental illness, but to do with a physical health issue. But whilst he was triaged very quickly to the mental health team. So I think we've just got some systemic issues to really address. That's just an example in ED. And so how do we shift the system to think about the person in a holistic way? A person's mental health diagnosis, as we saw in that particular example that I put, may dominate their interaction with the health system, even if they are overweight, have high blood pressure or diabetes, or have a heart condition or other risk factors. And can I say, picking up the GP, the stuff that Sam talked about, I had this opportunity to work at the front line a number of years ago, probably not too long ago now, for example, in Headspace, as an example, where we employed and had GPs. But the major issue was that those GPs saw themselves as only doing mental health care plans. So when young people were coming in, they weren't even considering their physical health needs. And until we got a fairly savvy practice nurse manager who worked with the GPs and said, what about the other health issues? Why aren't we doing sexual health? Why aren't we referring people to various other blood tests, etc., that started to change. And so we were starting to see a much more holistic approach to both young people that were turning up around their, usually situational crisis linked to some sort of mental health, distress or stress, but we were also starting to really push around looking at the physical health issues. And that was just an example of trying to shift within that system where, for example, primary healthcare was one of the key players, seeing young people probably first when they turned up to a Headspace. but also people in this space receive different responses and levels of service depending on whether they are seen for a physical health issue first or a mental health problem first. But also some will suffer from both. And again, with my own experience, having to even implement a health check within a mental health organisation, that in actual fact you could do a health check and ask some questions when a person is coming to see you around mental health is a really challenging issue to actually put in place. And I can tell you why as well, because, and I'll talk more about that, it's around picking up Sam's point, it's around the time of people having to do a much more comprehensive assessment or screening rather than the 12, 15-minute medicine that we particularly see in general practice. I would suggest that we must start from the premise that human beings are much more complex than any one label would suggest. The literature tells us that the healthcare workforce, both generalists but also specialists, currently lack the opportunities, and I use the word particularly their opportunities, to respond in a holistic and integrated way to complex comorbidities. How many services are providing the opportunities that Sam is doing at one CCU on the Sunshine Coast? How many services are thinking about that in that way? I think that's what we've got to try and shift and move. We need to create a health services culture where mental health and physical health needs are seen together instead of treating mind and body separately. And the evidence is clear. Sleep, diet, connection, so critical to mental health outcomes. But do we take that into consideration when we are seeing people with comorbidities? We must use the best evidence-based practice to manage both paradigms concurrently, but also effectively. While it's unfair to expect every medical professional in the health and mental health system to have all the necessary skills, at a systems level though, if we think from a systems level, we can, however, certainly expect better integration. I think Christine and Sam and others all talked about better integration between physical and mental health services, but also how do we build multidisciplinary teams and expertise to support people and provide the treatment that they need, both in terms of physical and mental health, to achieve the holistic outcomes that the person really requires. For example, as I said, we need to drive a culture of integration, and it's not just integration with physical health, etc. We've got the word integration in mental health is so bandied around, but if you hear consumers speak about what that means for them, I think we're a long way away. So I think that concept, we use the word regularly, but I don't think it's actually grounded adequately within our service delivery system, both within the health system, if we're thinking about health and physical health, mental health and physical health, but also mental health and other systems. Acknowledging the interplay between physical and mental health means that the mental health system becomes more clearly a partnership. So the system becomes a partnership between people who experience mental ill health, their friends, loved ones and carers, and support and treatments available from a large variety of voluntary, community, social, but also health services. I believe we can create an expectation that people will be actively, effectively and meaningfully involved in their own treatment and care. And I think it was Sam's point around, it's not something that we can impose on people, but part of our work as clinicians, as support workers, as peer workers, is how do we engage people in their own care, whether it's physical and mental health or both. Picking up some of the discussion earlier, we certainly at the Queensland Mental Health Commission in 2021 consulted with lived experience to learn from their perspectives on improving physical health of people with lived experience of mental illness and or problematic alcohol and other drug use, the strategic position paper that was published. We wanted to get people's opinions about the reform opportunities, again at a systemic level, raised in that paper, and identified their perspectives and their preferred priorities for taking forward and investment. People with lived experience identified several key areas of reform. Some surprising, some not so surprising. This includes prioritising areas with the highest burden of disease, but also socioeconomic disadvantage, for co-designing strategies focused on health promotion, keeping people well, thinking about sleep and diet and exercise, etc., etc. They were some of the real key things that came through. They also identified that we need to invest in capability building to strengthen the skills and competencies of the workforce, but particularly focus on the education of people with lived experience and employing them in a range of roles. They talked about training in compassionate and empathetic communication. I want to pick up a point here, and it was picked up in the Productivity Commission report as well, that, we have on average, if I talk about the public system, our clinicians spend 20% of their time in a day facing clients. 20% of the day facing clients. If you take client notes, related client notes, it's 29%, when the benchmark is 67%. In the private sector, it's 85%. So you can see that we've got some work to do about freeing up clinicians to be able to do a whole range of other things, including a focus on physical health issues, which I think at the moment when I talk to clinicians out there, it's both whether you talk to general practice, you talk to people in the public system, this time frame, what they've got to work with people, to establish relationships, to engage people in their own care and treatment, is just not available. And we've got a whole range of system changes we need to make to be able to enable clinicians to do that. We also need to strengthen those partnerships between, health and community organisations to really strengthen the component that Sam talked about, social connection, and the importance of that to both physical and mental health outcomes. We need to promote the importance of the psychological and physical well-being of families and carers. Certainly came up strongly in the work that we did with individuals in Queensland. If you've got to keep both the health and mental health of carers at the forefront to be able to also support people with a lived experience of mental health, but who also may have other conditions, health conditions, how do we make sure that carers are well to keep their loved ones well? We also need to, and it was talked about this morning, Tom Bryson spoke about it, other people spoke about it, the co-designing of models of care with people with lived experience, particularly people from Aboriginal and Torres Strait Islander backgrounds. We heard around culturally and linguistically diverse backgrounds, but also from the LGBTI community. The final few bits from a systems perspective that this particular group of people identified as really critical to take forward is making the reform opportunities clear and understandable to all. A lot of the times we talk at certain levels, but it's hard to translate some of that stuff into practice. And I think it's that evidence translation into practice that I think we've got to do more. So, we've got some phenomenal policies and statements and directions, etc., where we fail generally is a translation of those into implementation. But also, we need some clarity in roles and responsibilities of our health professionals across a whole range of domains. There is still a lack of clarity, but also how do we make sure that we have the various skill sets involved in a person's life, and not just, as I used at a sort of ED example, the moment I turn up because I've got a history of mental illness, I get channeled very quickly and triaged to the mental health team. Don't worry about all the other health problems that I've got. And can I just sort of finish off with that, such reform opportunities that I tried to talk about there at the systems level, support our Commission's commitment to the Equally Well National Consensus Statement for improving the physical health and wellbeing of people living with mental illness in Australia. And a couple of practical things that we are starting to sort of work with agencies, government, non-government, private, just to start this stuff, because Sam's pocket of excellence, can I say, aren't systemically applied across the system. We've got great pockets of excellence, but I can tell you from a systems thinking perspective, we've got a long way to go before that becomes part of the health and mental health system. But what I would suggest is that we need to focus on innovative, actionable steps. People need to start to at least to be able to take some steps in the right direction, and it will take us time to get there, but I think we've got to give some practical steps to take it forward. For example, we need to ensure that physical health screening is fundamental to healthcare as mental health screening is, and vice versa. Picking up Sam's point, when we are doing some of those initial assessments and triage, etc., how do we look at the biopsychosocial assessment? I know it's going to, but I'm going back to that point I made earlier. We need to free up clinicians to have the time to do that. We need to provide the opportunity for people. It's not that our clinicians and health workers and peer workers don't want to do that. The challenge is having the time to do all of that and to be able to integrate that. I think some of the stuff that I think you touched on, Sam, and other people, but certainly that's come through the work that we've done, is around the psychoeducation that's required around physical health and mental health with families and individuals, etc. Because we tend to focus on different aspects of that, but how do we provide psychoeducational opportunities for families, carers, but also the individuals that cover across particularly both of those? We need to provide, as I think Sam has said, but I've said already, time for staff to be able to do this type of work. We seem to be, and I'm here representing, and I'm sure there's quite a few of you here in the audience, like we do with the education system. We add things onto people. You've got to do this now, you've got to do that now. It's just, people are struggling to be able to incorporate all of that. So we need to free up the system to give staff more time, and then I think people will be able to take on additional work such as this and see it in a much more holistic way. The other bit that hasn't been picked up in the discussion, at least from this morning, it may have been because I wasn't here yesterday, was about the stigma associated with mental illness. And we know that stigmatizing attitudes exist even in the public mental health system, the NGO system, and the private system. But stigma is probably even higher in the non-mental health sector. And I'm making a gross generalisation there, but I'm telling you that from at least some of the sort of evidence that I've read, that generally stigma will be the major driver why people don't get the holistic response we need. Like again, I felt an element of that with that ED example that I used, and I've heard about those ED examples fairly consistently. It was a level of stigma that I think influenced some of those decisions around where the person was actually triaged to. Even some of those things, if we could move forward systematically and then look at some pockets of clear excellence and work that we're doing and how do we make those more systemically available, I think we'll be much further down the track. We at the Queensland Mental Health Commission, we want to work in this area to drive this agenda forward. And as you know, we've been committed to this space and we've done as much as we can and we continue to drive this. And I think this forum is again an important forum to ignite conversations, but also from us to learn from each other about some pockets of excellence, where people have had some successes around system change, but also how do we embed some of that more long term. Can I say when any system change that at least I've been involved with, it's not going to happen just because we at the Commission are pushing it, or even organisations such as Equally Well Australia. But collectively, I think we can actually achieve this. And can I say that these forums are designed, at least from my perspective, and why we support this and why we're engaged, is that when you go back into your everyday work, you have an opportunity to take some of these things forward. Remember, it's not just when we think about leadership in this space, it's not just people who sit in so-called leadership positions. In fact, we are all leaders in our own right. We all have spheres of influence. We all have our connections. It's about what you're going to take away into your environment to be able to address, particularly from the learnings over these 2 days, what can you take away and embed within your environment about addressing both the physical health and mental health issues of people with mental illness. Thank you for the opportunity to be here, and I look forward to the outcomes of this forum. Thank you.
All right, thank you everyone. Some really great words from Ivan. I think that's thinking about time, competing priorities and stigma as being real barriers to holistic care.